The way cancer screening is taught today is built on a foundation that most people assume is solid, but the truth is far more complicated. The standard recommendations you hear in clinics and guidelines come from studies that have already been re-examined multiple times over the years. And each time those studies were reanalyzed, the conclusions shifted. In some cases, those shifts were not small adjustments, but major changes in how we understand risk, benefit, and harm. Even more concerning, many of the clinical guidelines still being used today are based on research that is more than a decade out of date. In certain screening tests, the gap between current evidence and official recommendation is even wider. That creates a situation where what is widely practiced in medicine does not always reflect what the most recent data actually shows. This discussion is not about rejecting mainstream medicine entirely. It is about recognizing where the evidence is more complex than the simple messaging patients usually receive. In particular, there are 5 cancer screening tests that are either widely recommended, heavily marketed, or both, but where the accumulated evidence raises serious questions about how they are used in routine care. At the same time, there are also 3 tests that are far less commonly discussed, but which the current research actually supports in meaningful ways. Interestingly, one of these is rarely even mentioned in standard physician visits, despite its potential significance. Before going deeper, it is important to set a clear boundary. Everything discussed here is educational and based on published research. It is not personal medical advice. If someone is currently under treatment for cancer or any related condition, these ideas should only be used to inform conversations with a qualified physician, not replace them. Every clinical decision depends on individual history, risk factors, and context. With that clarification in place, the real issue becomes visible. There is a growing gap between what is marketed as routine cancer screening and what the data actually supports. To understand that gap properly, one key concept needs to be introduced early: overdiagnosis. This idea will come up repeatedly because it fundamentally changes how screening results should be interpreted. Overdiagnosis does not mean a false positive. It does not mean a scan incorrectly says cancer is present. Instead, it refers to situations where a real cancer is detected and confirmed, but that cancer would never have caused harm during a person's lifetime. It might grow so slowly or remain so biologically inactive that the individual would have died of something entirely unrelated without ever knowing it was there. In simple terms, it is like a fire alarm going off in a room filled with harmless steam rather than smoke. The alarm is real, the detection is real, but the response it triggers may not always be necessary. This distinction becomes central when evaluating modern cancer screening programs, because once overdiagnosis is accounted for, the balance between benefit and harm becomes far less straightforward than most people assume. The 5 screening approaches under discussion include annual mammography across all ages, PSA total as a routine yearly marker, full-body MRI offered directly to consumers, thyroid ultrasound in asymptomatic adults, and coronary calcium scoring in low-risk individuals without symptoms. These are not fringe ideas. Several of them are part of official guidelines, and others are actively marketed by major healthcare systems and private companies. Yet the evidence behind each of these tests is more nuanced than the recommendations suggest, and that nuance matters because screening is not neutral. It always carries consequences, both in what it detects and what it leads to next. With that foundation established, the discussion now moves into the first major example: mammography, and how decades of data have reshaped what we think we know about breast cancer screening. Mammography is one of the most widely recognized cancer screening tools in modern medicine, and for many people it represents the standard example of early detection saving lives. But when you look closely at the long-term data, the picture becomes more complex than the simple message often communicated in public health campaigns. A key turning point in how researchers began to reassess mammography came from a major paper published in 2012 by Gilbert Welch and Archie Blyer, using decades of national data from the United States. The study examined breast cancer diagnosis trends over a 30-year period from 1976 to 2008, covering the time when mammography became widely adopted across the population. What the researchers found was unexpected. As mammography screening expanded, breast cancer diagnoses increased dramatically. In total, the data suggested around 5 million additional breast cancer cases compared to what would have been expected without widespread screening. This finding is not easily dismissed as a statistical error or minor fluctuation. It reflects a large and persistent increase in detected cancers that cannot be fully explained by changes in underlying disease rates alone. To understand why this matters, it is necessary to return to the concept of overdiagnosis. This is not about mistakes or incorrect test results. These are real cancers, identified through real imaging, often followed by real treatment. Surgery, radiation, and sometimes chemotherapy are all involved. The key question is not whether the cancer exists, but whether it would ever have become dangerous. In cases of overdiagnosis, the answer is no. The tumor may be so slow-growing or biologically inactive that it would never have caused symptoms or shortened life expectancy. The person would have lived their entire natural lifespan without ever knowing it was there. Welch and Blyer estimated that roughly 31% of mammography-detected breast cancers fall into this category. However, other research using different models has produced a wide range of estimates, from as low as 10% to as high as 54%. While there is disagreement about the exact number, there is no serious disagreement that overdiagnosis is a real and meaningful phenomenon in breast cancer screening. At any point in that range, the implication remains significant. It means that a substantial number of people may undergo surgery, radiation, or long-term hormonal therapy for cancers that would never have harmed them. This does not mean mammography has no value. That would be an oversimplification in the opposite direction. There are clearly cases where early detection has identified aggressive cancers at a stage where treatment has saved lives. That benefit is real and well documented. The more accurate way to understand mammography is through balance. The benefit exists, but it is not uniform across all populations. Age, genetic risk, family history, and breast density all play a major role in determining whether screening is likely to help or potentially lead to harm through overdiagnosis. For example, in women under 50, the evidence for clear net benefit is relatively weak, which is why screening guidelines have shifted over time and continue to be debated. In women over 75, the balance often shifts again due to competing health risks and the reduced likelihood that early detection improves overall outcomes. For individuals with high-risk factors, such as BRCA mutations or strong family history, the equation changes significantly in favor of screening. In those cases, earlier and more frequent monitoring is generally supported. What becomes clear is that mammography is not a one-size-fits-all recommendation. It is a risk-stratified decision that should depend on individual biology and context rather than a uniform schedule applied to everyone. This same pattern of complexity appears in other widely used screening tools, particularly the PSA test for prostate cancer, which introduces an entirely different set of challenges around interpretation, overtreatment, and risk. The PSA test is one of the most commonly ordered cancer screening tools for men, often included in routine annual blood work without much discussion about its limitations. On the surface, it seems straightforward, a simple blood marker that can help detect prostate cancer early. But when you examine the evidence more carefully, the situation becomes far less clear. There are two major randomized controlled trials that studied PSA screening at scale, and interestingly, they did not reach the same conclusion. One of the largest was the PLCO trial in the United States, which followed more than 76,000 men between the ages of 55 and 74 over a 13-year period. Its result was striking in its simplicity. Routine annual PSA screening did not produce a statistically significant reduction in prostate cancer mortality. In other words, no measurable survival benefit was seen from widespread screening in that study. At the same time, the European ERSPC trial, which used a different design and population, found a different outcome. It reported approximately a 21% reduction in prostate cancer mortality among those who underwent PSA screening. Two large, well-conducted studies, yet they point in different directions. This disagreement is part of why PSA screening remains controversial in clinical practice. Rather than trying to force a single interpretation, it is more accurate to focus on what PSA testing actually measures and where its weaknesses lie. The core issue is that total PSA is not a specific indicator of dangerous cancer. It cannot reliably distinguish between aggressive tumors and slow-growing forms that may never cause harm. In fact, a significant proportion of prostate cancers detected through screening are classified as Gleason 6. These are often described by pathologists as very low-risk tumors, and in many cases, they behave in a way that does not align with the typical idea of cancer progression. They tend not to invade surrounding tissue or metastasize, and long-term outcomes often show that they do not contribute meaningfully to mortality. Despite this, once a PSA level is elevated and triggers further investigation, the clinical pathway often moves toward biopsy. This step is not without risk. Prostate biopsy carries a documented chance of complications, including infections severe enough to require hospitalization in about 1 to 3% of cases, along with bleeding, urinary retention, and significant psychological stress while awaiting results. If cancer is detected, even low-grade forms like Gleason 6, treatment decisions often follow. Procedures such as radical prostatectomy, radiation therapy, or hormone suppression can have serious long-term consequences. These may include permanent erectile dysfunction, urinary incontinence, and bowel complications, all of which can significantly affect quality of life. Because of these downstream effects, major guideline bodies such as the U.S. Preventive Services Task Force have taken a cautious position. At one point, they recommended against routine PSA screening altogether, and later revised their guidance to emphasize shared decision-making rather than automatic annual testing. The intention was not to dismiss PSA entirely, but to highlight that the decision is not as simple as ordering a routine lab test. A more refined approach has emerged in recent years with tools like the 4K score. Instead of relying only on total PSA, this test measures multiple kallikrein proteins and produces a risk estimate for clinically significant prostate cancer, particularly higher grade disease such as Gleason 7 and above. This distinction is important because it shifts the focus away from simply detecting any cancer and toward identifying cancers that are more likely to cause harm. For example, if a man has an elevated PSA but a low 4K score, indicating a very low probability of aggressive disease, it may be reasonable to avoid immediate biopsy and instead monitor over time. This can reduce unnecessary procedures and the cascade of interventions that sometimes follow uncertain findings. Of course, context matters. Individuals with a strong family history of prostate cancer or consistently rising PSA levels require a different level of attention and follow-up. The goal is not to avoid evaluation, but to improve how risk is assessed before moving into invasive steps. This pattern, where a simple test leads to complex downstream consequences, also appears in other forms of screening, particularly those that involve imaging technologies capable of detecting incidental findings that were never the original concern. That issue becomes especially clear in the case of full-body MRI marketed directly to consumers, which is the next part of the discussion. Full-body MRI scans marketed directly to consumers have become increasingly visible in recent years, often presented as a way to gain complete insight into what is happening inside the body. The promise is simple and appealing. Detect anything early before symptoms appear and take control of health in advance. However, when this approach is evaluated against clinical evidence, the outcomes are far more complicated. These scans are typically offered without a physician referral and are promoted as preventive tools for otherwise healthy, asymptomatic individuals. The logic behind them is understandable. If imaging can see inside the body in high detail, it feels intuitive that more information must always be better. But medicine does not operate on information alone. It also depends on how that information is interpreted and what it leads to. A large body of evidence on incidental findings helps clarify this issue. A systematic review published in the British Medical Journal examined more than 40 studies over several decades, focusing on what happens when imaging is performed without a specific clinical question. Across this research, a consistent pattern appears. Approximately 40% of adults who undergo whole-body imaging, whether CT or MRI, receive at least one incidental finding. These are unexpected observations that were not the reason for the scan. Many of them require follow-up testing, not because they are likely dangerous, but because they are uncertain and must be investigated further. Of those individuals who enter this follow-up process, a large proportion undergo additional procedures, including more imaging, laboratory tests, and sometimes even biopsies. Yet when outcomes are traced to their conclusion, only about 1 to 2% of all scanned individuals ultimately have a clinically significant finding that requires meaningful intervention. This creates a wide gap between detection and true medical benefit. A scan designed to find everything inevitably finds many things that are not clinically important. These include benign cysts, harmless liver lesions, small adrenal nodules, and other anatomical variations that are extremely common in the general population and often never cause any symptoms. The challenge is not that these findings are false. They are real structures seen on imaging. The challenge is that their discovery triggers a chain of medical actions. Radiologists are required to report them, and physicians are often obligated to follow up, not because the findings are likely dangerous, but because medical standards and legal frameworks encourage caution. This creates what is often called a cascade effect. One scan leads to another test, which leads to another evaluation, which may eventually lead to invasive procedures. Each step adds cost, stress, and potential risk, even when the original finding was ultimately harmless. Statistically, estimates suggest that around 1 in every 500 incidental workups results in a serious adverse event, which may include procedural complications, unnecessary hospitalization, or significant psychological distress. These are not rare outcomes when viewed at population scale. Importantly, despite the growing popularity of full-body MRI in commercial settings, there are currently no randomized controlled trials demonstrating that this approach reduces cancer mortality in asymptomatic adults. This absence of evidence is significant. It means that while these scans can generate a large amount of information, there is no clear proof that they improve survival outcomes in healthy populations. This distinction is essential because the value of a medical test is not determined by how much it detects, but by whether it meaningfully improves health outcomes. Without that evidence, the benefit remains theoretical, while the risks of overdiagnosis and overtesting are well documented. It is also important to separate this from medically indicated imaging. When a physician orders a scan based on symptoms, abnormal laboratory results, or known genetic risk factors, the context is completely different. In those cases, imaging is targeted and clinically justified. The concern here is specifically about direct-to-consumer screening in people without symptoms or known risk. A similar issue appears in thyroid ultrasound screening, which has produced one of the clearest real-world examples of how increased detection does not always translate into improved health outcomes. That case provides Another important lesson in how screening can shift disease patterns without changing mortality. And that is where the discussion continues next. Thyroid ultrasound screening offers one of the clearest real-world examples of how expanding testing can dramatically increase diagnoses without actually improving survival outcomes. The most widely cited case comes from South Korea, where a national cancer screening program introduced thyroid ultrasound as an optional add-on during routine health checks in the early 1990s. At first, the test seemed harmless. It was inexpensive, quick, and easy to include in existing medical exams. Nothing about it appeared controversial. But over time, the population-level data revealed a striking and unexpected pattern. Between 1993 and 2011, thyroid cancer diagnoses in South Korea increased by approximately 15 times. In practical terms, the number of diagnosed cases rose from about 7,000 per year to more than 114,000 per year. This was not a small fluctuation or gradual increase. It was one of the largest rises in cancer incidence ever recorded in a developed healthcare system. However, during the same period, thyroid cancer mortality remained essentially unchanged. Despite the massive rise in diagnoses, the number of people dying from thyroid cancer stayed flat at roughly 1 death per 100,000 people per year. This disconnect between incidence and mortality is a key signal in epidemiology. It suggests that many of the newly detected cancers were not clinically meaningful. Instead, they were likely cases of overdiagnosis, tumors identified through screening that would never have caused symptoms or affected lifespan if they had remained undiscovered. In other words, the screening did not necessarily create more disease. It revealed more abnormalities that were already present but biologically inactive or extremely slow growing. The consequences of this shift were not trivial. Many patients underwent thyroid surgery, most commonly total thyroidectomy. While this procedure is effective at removing cancerous tissue, it is not without long-term risks. A notable percentage of patients experience permanent hypoparathyroidism, which affects calcium regulation, and a smaller but significant proportion suffer vocal cord paralysis. In addition, all patients who undergo total thyroid removal require lifelong thyroid hormone replacement therapy. This is not a minor adjustment. It represents a permanent change in the body's endocrine function, requiring continuous medication management for the rest of a person's life. What makes this situation particularly important is that many of these surgeries were performed for cancers that in retrospect may never have required treatment at all. The detection created a pathway of intervention that may not have been necessary for the patient's actual health outcome. This is why researchers and major journals, including the New England Journal of Medicine, have referred to the South Korean experience as a cautionary tale. It demonstrates how screening programs, when applied broadly without careful selection criteria, can lead to large increases in diagnosis without measurable improvements in mortality. This does not mean thyroid ultrasound is never appropriate. There are clear clinical situations where it is necessary, such as when patients present with palpable thyroid nodules, difficulty swallowing, unexplained voice changes, or irrelevant family history of thyroid cancer syndromes. In those contexts, targeted evaluation is justified. The issue arises when ultrasound is used routinely in asymptomatic individuals as part of general wellness screening. In those cases, the probability of detecting clinically irrelevant findings increases significantly, while the likelihood of improving outcomes remains uncertain. This same tension between detection and meaningful benefit also appears in cardiovascular screening, particularly with coronary artery calcium scoring. Unlike some of the previous tests discussed, this one does have a clear role in certain populations, but its value depends heavily on who is being tested and why. When used in the right context, it can improve risk stratification. When used in low-risk populations without symptoms, it raises similar concerns about downstream testing, radiation exposure, and unnecessary interventions. Understanding where that boundary lies is essential to interpreting its role properly, which leads into the final part of this discussion.